housekeeping for you. For those who need CEUs, LPC, LMFTs, or social workers, please enter the sign-in code, which I will announce shortly, and then use the link on your chat box. The sign-in link will be live for about 15 minutes. Also listen for the sign-out code, which I will do prior to going into questions and answers for everybody. You will need to provide your name and license type for your CEUs when you fill out the conference evaluation at the end of the conference. And you must complete the conference evaluation for your CEU to be processed. You will receive your CEU certificates as soon as possible after the conference at the email address you used to register. We hope that everyone, regardless of CEUs, will complete the conference evaluation. This helps us plan for future conferences and how we want to do this. And as you know, this is our 5th annual, and we do appreciate everybody. Understand that we have on this virtual, working around this is a major workload for everybody, and we appreciate your patience in working with us. So the CEU signing code for this session is 50. Now, what I'd like to do is basically I introduce myself, Michael Azito, and I work for the Office of Criminal Justice here in Bexar County. So I am from San Antonio. I know a lot of you may be from out of town. So this is Bexar County, San Antonio, Texas, and I oversee the medical examiners, the crime lab, pretrial services, our reentry services, and also the mental health department, which brings me to you. And this is a very good opportunity. I was real happy that we were able to do this workshop because we were able to get some really good speakers for you, and we're proud of it. But I know everybody experiences something now with COVID. It's been an interesting experience on that end now because, you know, loved ones aren't even able to get in to be with family members, even if they have COVID or whatever. Even on a mental health crisis, it's very difficult because they don't want to spread COVID in the facility, so they're being very secure as to what goes on. So it's even harder to get communications going. But in normal times, it's also difficult. And that's really what we wanted to do here, was really look at navigating the system and being able to look at the system and find ways that you're able to communicate with the doctor, with the staffs, no matter what the issue is. And that really brings us to our speakers that I have today. Our first speaker will be John Petrilla, and he's going to have about 25 minutes, and he is the Senior Vice President of Meadows Mental Health Institute. This is a super organization for the state of Texas, as they are the individuals that have stepped up to advocate for mental health with our legislature and have gotten millions and millions of dollars for mental health programs, have brought the education to the legislatures to understand how mental health is health, and it does impact quite a few people within our country and within the state of Texas. And they have also helped us here locally with our programs, with our South Texas Crisis Collaboration, which I think is premier. I don't think there's another program like that in the country. And they help us design it and work with law enforcement, actually divert individuals to a psychiatric hospital rather than the jail or an emergency room. And they divert about 1,200 people per month. So this has had a tremendous impact on emergency, not having individuals with mental health issues in emergency rooms that could go straight to a psychiatric facility, especially in this time of COVID. So Dr. Petrilla has his law degree from the University of Virginia, and he has quite an extensive background. He was a professor and chair at the University of South Florida. He served as the director of Florida Criminal Justice and Technical Assistance Center in the state of Florida. He also was with the New York State Office of Mental Health, where he was the deputy commissioner and general counsel. He was also director for forensic services in Missouri. He was assistant attorney general. I think this is a great opportunity for us to have somebody, what I believe is on a national basis. I believe in the approach of presentation as a funnel to get the national perspective. How does it apply to everybody in the United States, and then to funnel it down to a fine tune to locally. And so that's our next speaker that will come up after John Petrella is Luis Santos. And he is kind of the rubber meets the road person, because he has worked as the director as a manager with the University Health Systems. And University Health Systems is our county hospital. And they are a big player within Bexar County. They provide jail services, mental health, and health services at our jail. They also have a huge hospital system, children's specialty, all kinds of specialties, especially in trauma. And he has worked at every level within hospitals on social work. He has his degree in psychology from Baylor University, and then he has a master's degree in social work from the University of Texas at San Antonio. So we are very pleased and have a great group of presenters here that will really be able to talk to you about HIPAA, but I think we'll give it from all levels. And then with Dr. John Petrella being with us, being a lawyer in that process, I think he's participated and written a lot of books. And so John, take it away.
All right, Mike, thank you so much. It's a great pleasure to be here. And it's a particular pleasure to be able to do this with Luis Santos, who knows these issues both at a sort of a policy level, but very much at a clinical level. So it's very nice to be able to do this with him as well. I was asked to talk about HIPAA, hospitalization, incarceration, and finding care. So I'm going to go quickly through some changes in what's happened at the federal level in response to COVID and also policing issues, and then talk a little bit about Texas law specifically. I know there's lots of folks from around the country, and I think some other countries on this at this conference. So this may or may not be relevant all the way through to all you folks. Certainly Luis Santos' presentation on how to navigate this from a clinical perspective will be relevant to everyone. So I'm going to start with sort of the way we often experience information sharing, right? So we are all aware of the importance of information sharing. On the other hand, often when we request it, the answer is no. And there's a lot of reasons the answer is no. Some is a misapprehension of law. Some is sort of a lack of ability on the part of the person requesting information to differentiate why the information might be important. And so I think part of what we're after is exploring what the law permits, and then whether you go as far as the law permits is a separate issue, but and there's issues of values of privacy, there's ethical concerns, but often the conversation doesn't get developed very far because of the suspicion of folks who may want to get some information. Part of the issue then is trying to decide in advance and be clear in advance what information might be useful and to what end. So it's very different if you want to get clinical information about a person for the purpose of providing continuity of care. That's going to take you down one legal path. That's different than if you're trying to do program evaluation, where you may be able to assess the success or failure of a program without looking at individually identifiable information. We try to achieve efficiencies in care. That can be done by looking at the experiences of individuals, and again, as Mike said, Bexar County's done a phenomenal job with the navigation system and trying to focus on creating better efficiencies across the board for folks whose care costs a lot of money, and then providing better decisions at the point of earliest encounter. So one of the questions is always, if you're interested in access to information, is being able to articulate the reasons why and the goal. One of the things that's changed in the field as well over 30 years or 40 years is that we used to have enormous technological limitations on the ability to share information. When I started my career, a lot of it was spent representing state hospitals, and I remember the medical records of folks who'd been there 15 and 20 years, and they're just the volume of paper. And so trying to share information in that context beyond for the next caregiver, or if a court subpoenaed something, was very difficult. Now we've got technological solutions to virtually every issue about how we could share information, but data security then becomes a major part of the puzzle. And we spend a lot of time discussing privacy issues, and I think sometimes we spend less time than we should talking about the fact that data security is the best buffer against unwarranted intrusions into privacy. So point one is technology is not the issue, but security is essential. Point two is that privacy is an extraordinarily important value, but it's not an absolute value, either legally or ethically. And so all of you, if you're a clinician, know that you may be obligated or have permission to talk to a third party who your client says they're going to hurt. That's an exception to both the ethical norm and the legal value of privacy. So we want to keep clear that while privacy is essential and important, it's not unlimited. Third issue is that risk management and risk aversiveness are not the same thing. So I view my role, if I'm acting as a lawyer, as trying to help my client assess relative degrees of risk, recognize that there is virtually no enterprise in clinical care, certainly, where there is zero risk, and then assess sort of how does one manage risk, and that we recognize we must assume some risk at some points, and that includes with information sharing. That's different than saying, I'm going to try as a lawyer to help you avoid all risk. That's an unrealistic position. It means a much more cautious approach to this issue than sometimes is useful. And finally, I want to suggest that the cost of not using information for these goals is very high and has gotten higher. I'm going to spend a couple minutes talking about the impact of COVID and police reform, because those issues have already had an impact on the way the federal government's looking at information sharing. So we anticipate, and I'll show you a table in a minute, that there will be increases in suicide and substance use deaths associated with the economic downturn caused by COVID, with people's isolating and quarantining at home. COVID clearly disproportionately impacts communities of color. We have enormous infection rates in congregate living spaces like jails and prisons. We're trying, particularly with some greater urgency in the aftermath of George Floyd, to reduce unnecessary police contacts, and the sort of bad policing, when it does occur, disproportionately affects communities of color, as does COVID. And we anticipate some erosion of treatment capacity because of COVID, but also an uptick in the use of telemedicine and teletreatment. So again, just to make the point, and without belaboring this, we did a series of studies looking at the correlation between unemployment rates as they accelerated and suicide. We estimate, based on that historic data, that for every 1% increase in unemployment, we'll see a 1.6% increase in suicide, or something equivalent to it. We'll also see an increase in drug overdose deaths due to rising unemployment. The CDC issued a study the other day that suggested, as I recall, 1 in 10 young people had thought about suicide during COVID. So we anticipate this increased demand. And as Mike Lozito said in introducing this session, it makes sharing information for care purposes, for assessment and continuity of care, even more critical than it's ever been. And that includes not just as appropriate with clinicians, but also as appropriate with first responders. So let me just quickly go through 2 or 3 changes that have already occurred in federal law in light of COVID and in light of the opioid epidemic that's affecting many parts of the country. This is, without going into a lot of detail, a clarification of HIPAA made clear that people's individual names and other identifying individual information who've been infected with or exposed to COVID can be shared without the person's authorization to law enforcement, paramedics, and other first responders. This ties to what a lot of communities are trying to do to make initial response to mental health crises less law enforcement anchored and more based on paramedic and clinical response. But this is an explicit recognition by the Office of Civil Rights and the federal government that in a pandemic, there needs to be clarity that first responders can get information, and that includes law enforcement. So that's one change in federal law. And these are the reasons that they articulated for that, or when that information can be shared. And I won't go through those, but it's essentially to help deal either clinically or in terms of public safety with the issue at hand. And so that's one change. The second change, this is a statutory change. There's been, those of you on this session who do a lot of work with substance use know sort of the lack of fit between the federal regulation 42 CFR Part 2 that deals with substance use and alcohol information and other parts of the law that deal with health information, mental health information. What the CARES Act did, and so this is in statute, this will last beyond the pandemic, is that it makes 42 CFR easier to administer in terms of consent provisions. And so it broadens consent by saying that once a person gives prior written consent to disclosure, that the records can be used or disclosed for these various purposes, including treatment and healthcare operations. Again, without going into great detail, it brings 42 CFR closer to where HIPAA is. And I anticipate over time that that will continue to be the trend, because there's been, this is about the third time that the feds have made some change in 42 CFR to move it closer to HIPAA. This is really the first kind of major statutory provision. So that's something worth keeping in mind. And then in terms of telehealth, again, without going into detail, been an enormous relaxation of the regulatory standards that govern the use of telehealth. And clearly, many of you on this call have probably seen an uptick in the use of telehealth since COVID emerged. And, you know, we can anticipate that's likely to continue, at least to some significant degree. And so there's been an enormous relaxation of the regulatory rules around the use of telehealth and data security. And I think if you're into the use of telehealth, and I'm using that as a term for a much, you know, obviously broader set of technologies, that it's important to recognize that the trend is to try to create a more relaxed regulatory framework that accelerates and expands the use of telehealth in general as we go forward. So those are just three changes that have occurred in federal law in the last 6 months or however long COVID has gone on. And we anticipate more. And again, I think COVID, the need to rethink and reshape police response in some areas, especially with medical crises, has made it even more important that we recognize that the law may permit information sharing beyond what people often assume it is. So let me turn to Texas law, because Texas law, especially around sharing of information for folks who are justice involved, either in the adult or juvenile system, and also have a mental illness, Texas law was really one of the first in the country to take that issue on and try and create a more integrated kind of synthetic approach to information sharing. So HIPAA sets the floor. States can be more conservative than HIPAA, but they cannot be less in terms of protecting rights. And Texas law, again, fits very nicely with sort of the underlying premise of HIPAA, that we want to assure continuity of care, that we want to assure care gets paid for, and things like that. So let me just quickly go through a couple of exceptions. Texas law permits information sharing. In some places may appear to require it, and Luis is going to come back to that issue. But there's not a big gap between Texas law and HIPAA as it affects folks who may hit or at risk of being in the justice system. And so I want to then, and that's in contrast to a number of states. There's a few states where the law is much more conservative and much more restrictive than HIPAA. And so it creates difficulties in navigating the federal and state systems. But let me go through a couple of examples. The Texas statute includes the Medical Privacy Act, the Mental Health Records Act, and then the Exchange of Information Act, which I'll come to. The Mental Health Records Act permits disclosure without consent in a number of circumstances, including in an emergency for treatment purposes, again, for continuity of care, or to correctional personnel for care or treatment, which is very similar, the last section, to HIPAA, which permits correctional authorities to have access to protected health information for one of 5 stated purposes, but those purposes are very broad when you add them all up. So this does not suggest that consent's unimportant. It's only to say that the law permits disclosures without consent in these circumstances. And so it's worth keeping that in mind. If you think about the intercept model, sequential intercept model, at the point of intervention, those of you familiar with this model, Texas Health and Safety Code permits health information to be given to law enforcement if there's a risk of imminent physical or emotional harm. HIPAA also permits PHI to go to law enforcement in the event that there's a threat to health or safety. And so that's something where both Texas law and federal law permit first responders and law enforcement to have access to some information. Intercept 2 is the point of initial detention. I won't try to belabor this, but again, Texas law, as federal law, permits clinical information to go to correctional facilities if it's for the purpose of treatment and healthcare under Texas law. And those of you on this call know, if you work in the area of justice at all, the tremendous discontinuity of care once somebody enters a jail. And often it's discontinuity of care around medication, and people don't have access in the jail to what the medication regime is on, the person's on, and so that can create enormous discontinuity, leaving aside limited pharmaceutical and sort of whatever. But that's an important exception in law as well. The Texas statute dealing with exchange of information for justice-involved people, that again was at some early days a model for this type of information sharing, says an agency shall accept information relating to a special offender, juvenile with mental impairment, to serve the purposes of continuity of services, regardless of whether other state law makes that information confidential. So again, Texas law is very clear that for purposes of continuity of care, that information can be shared broadly across multiple types of agencies in the interest of dealing with folks, addressing the needs of people who are involved and in need of care. These are just a snapshot of all the agencies the statute specifies, and it ranges from the hospital district to the Board of Pardon and Parole, to local jails, to public safety, to the local health department. And again, a statutory scheme that is very much prefers and expresses an explicit sort of preference for information sharing in the interests of care. Similar in many ways, again, in its spirit to HIPAA. This was a law, or the HHSC has actually been very attentive to this issue in the context of its work. And this was from a letter from HHSC and a couple of years ago. HHSC, in examining or looking at the exchange of information statute I just referenced, says that it requires mental health providers regulated by or under contract with HHSC to exchange information in accordance with the provisions of this statute. So again, statutory preference, regulatory as HHSC and its role as a contractor and regulator, preference for sharing information. It's not to minimize at all the importance of privacy. It's not to diminish it. It's a value, but simply that we should, before we say the law doesn't permit us to do something, we should examine sort of what the limits of the law really are, and then we can talk at a policy and practice level, do we want to go up to those limits? So other sort of things, as I said, substance use information is, we're going to see continuing changes in 42 CFR. Data security is essential and sometimes sort of underserved in our conversations about it. So I will now turn this over to Luis Santos with this thought that just because someone says HIPAA won't let you do that does not mean that that person actually knows what HIPAA says. And so I think it's useful to look at the actual text of these statutes and regulations before we declare that it drives us down one path or the other. I will stop there, and I will now try and turn this over to Luis, but let me...
You still have to maintain control of the slides, so Luis will tell you when to move the slides. Okay, sorry.
Not at all. All right.
Awesome.
Thank you.
Am I good on sound?
Yes.
Oh, excellent. So I really appreciate being able to participate on this panel, especially with somebody like John, who's served as chair of academic institutions. I'm currently a clinical social worker who's sitting on a chair, but that I want to bring to this part of the presentation what I have experienced as being a part of an emergency department crew or staff member, inpatient social worker at multiple hospital systems, things I've picked up, and then of course things that have been published as policy at the federal and state levels. So we can go on with the first slide. I want to first thank Charlotte and Nowcast because it has been a tremendous amount of work, and Terry Mabrito to put this virtually. I'm used to presenting at presentations like this when there's wonderful audiences where I can ask for a show of hands, and that's one challenge I'm going to have during this presentation. But before we go on any further, if anybody is still using that 20th century technology of pen and paper, or if you're using your smartphones, I'm going to encourage you to make space for 4 tips. I want to share 4 tips so you can basically get a piece of paper and write the numbers 1 through 4 and lines on it and have 4 tips, because the goal of my presentation is for you to be able to take these tips with you as a patient, as a family member of a patient, or as a person serving the patient. So I'm hoping that these 4 tips are something helpful. These are things that I've picked up along the way. And so with this first slide, when Nami's asking, hey, talk about how a person can navigate a crisis, and how can we consider involving family, and what does HIPAA let us do or not do? First, let's talk about, well, what exactly is a crisis, that moment when a person's safety is at risk. And in this realm, we're talking about the risk to safety is due to a psychiatric or mental health condition, even a suspicion of it, that gives a person a whole lot of rights. Just knowing that it might have at its root cause a mental illness. And how do you communicate this risk? Tip number 1, use verbs. Go back to elementary school and remember what a verb is, as opposed to a noun, or as opposed to an adjective, which we'd like to do in the 21st century, is do a lot of describing, but we forget to use verbs. Verbs like running, I run, I eat, I cook, I kick, I punch, I swallow, I hang, I shoot. Verbs. Get very familiar and fluent with verbs, because as you communicate risk and you communicate that the suspicion is due to a mental illness, verbs are where it's going to elevate a person's dignity to being able to clearly state, what is this crisis? What is this emergency? And how do we communicate these words to law enforcement, to the crisis hotline, to our case manager, to our cousin, to our parent who's been taking care of us? How do we communicate these words? Next slide, please. And when a person does arrive in the emergency room, one of the first things that happen in the emergency room setting is to determine, do I want to be there? Does the person want to be there? Or has the person been brought to the emergency room? If the person wants to be there, it's their decision. It's my decision. I want help. I know the cyclical nature of my mood disorder. I know that the season, or I've been out of the medication. I know what's happening. I'm in tune with my symptoms, my heralding symptoms. Remember what herald is? The guys that blow the trumpets and announce the coming of somebody very important. Those heralding symptoms, I know what it is. I'm bringing myself to the emergency room. Or has it gotten so difficult that the decision to come to the emergency room is not mine, it's somebody else's, in which case it's an involuntary visit to the emergency room. And that emergency room has to have good knowledge about the person's legal status, whether they're there voluntarily or involuntarily. What law enforcement uses is a measure called an emergency detention, and it is a form of detention, but it's not applied due to criminal reasons because somebody has been unlawful, but rather because somebody's in danger. So it's a detention that is made for safety reasons. And and our law enforcement in the city of San Antonio and Bexar County has been wonderful and huge pioneers in bringing clinical training to our law enforcement personnel. And when a 48-hour detention is applied, it's done on an emergency detention. We use that to allow a physician in the state of Texas to make a determination whether a person needs further psychiatric care, whether in the form of further evaluation or actual care in terms of treatment, psychotherapy, medications. If it's going to take more than just a quick visit, if it's going to take a few hours, we've got 48 hours. If the 48th hour lands on a weekend, then we got into the next business day at around 2 o'clock in the afternoon. And that involuntary stay can be so disempowering. It can be such a difficult moment. So going back to that tip number 1, please, tip number 1, type it into your memo section of your smartphone. Tip number 1, use verbs. Make sure that as we are compromising somebody's liberty, their right to freedom, we're able to communicate precisely why. In the next slide, please. The issue of disempowerment is something that we've elevated in to become very aware of at University Hospital in particular, the city of San Antonio and their consortium with the trauma-informed care. The idea of recognizing that a disempowering process could be a very traumatizing process. The spirit of trauma-informed care is to create a safe environment. In doing so, we typically take away people's belongings as they arrive in the emergency room. So here's another tip. You want to make sure that you are extracting natural support contact phone numbers. When's the last time you memorized the phone number? For me, I think it was 2005. In the cell phones, if you're a staff member at an emergency room and the person still has access to their phone, start gathering those natural support contact numbers, because that's what's going to help you bridge between our patient and their family, or their natural supports. I'm going to say natural supports often throughout the presentation. And what I mean by that is those folks who are not paid to care for our patients. Those who work as part of an agency or assigned to or ascribed to the person, those we typically call social supports. But HIPAA, as John has educated us, allows us and expects us to share information with our natural supports, particularly in the emergency room setting. In the event of an emergency, that type of information, we're telling them what the condition is and where they're located. How often have we encountered the situation where a loved one goes to a hospital, but then they're transferred somewhere else, and there's very little continuity of care? That could be incredibly scary. If you find that there are opportunities to help sequester the cell phones into a more accessible place, talk to your nursing director at your hospital if you're a social worker or a nurse and you're attending this conference, and try to come up with clever ways at being able to get a hold of those devices that very concretely connect us to our natural supports. And we can go to the next slide. In a couple of years ago, CNN came out with this really wonderful article highlighting how emergency rooms nationwide are saturated with activity, with work, and trying to help people access mental health care. And in doing so, there was this one contributor to this article, and she's talking about the arbitrary nature of accessing healthcare, particularly during a crisis. And she's referring to a moment where, for instance, she's quite under the weight of symptoms, possibly even hallucinating. I mean, very much at risk. She goes to the emergency room and is sent home with prescriptions. And the family knows that that's very scary. There could have been more. The level of care could have been higher. Only so that a few months later, when hopefully she makes it and she's okay, but has run out of these prescriptions and her doctor's appointment's not for another week, she goes back to the emergency room thinking she can secure another prescription. only to be told that the doctor believes she runs a risk because of a history of visiting emergency rooms, and now she's being hospitalized against her will. And so when I read this article, I had to go back to the dictionary and find out what arbitrary meant. And arbitrary is a hit or miss. It's kind of random, unpredictable. In trauma-informed care, we want to make things more predictable, less random. Next slide, please. And so I'm encouraging you to find and talk to your directors, talk to your leadership in finding ways to minimize the times or the opportunities when the person's visit to the emergency room in a crisis state is going to be arbitrary. How many of us have known of folks who have waited 17 hours in an admissions office because, one, there's not enough evidence to immediately start an inpatient level of care. So going back to tip number one, make sure that we're gathering these verbs, gathering the communication, these words that are going to indicate, yes, there is a risk to person's safety. How do we do that? We contact family. And in the emergency room setting, and here we have it on the slide, HIPAA is actually encouraging us to contact family and start gathering what we call collateral. Families are encouraged to give us as much information as possible. And I'm going to remind everybody, HIPAA is a federal guideline, the Code of Federal Regulations. If you ever wondered what CFR meant after the 45, it's federal level. If we go to the next slide, please. In Texas, as John had mentioned, it's sometimes states can be a little more strict than the federal guidelines. And I'm so grateful that I was able to present with John, because I actually learned that even though the Texas Mental Health Code says that permission to speak with a family member has to be in writing, there are actually guidelines, state guidelines that say, no. If it is to mitigate risk, if it is to avoid further crisis, your cost of not sharing this information with family or contacting family is much higher than trying to be risk averse. And I love that phrase that John taught us. Risk management is not the same thing as being risk averse. And so many of us, I have done this as well, when being a social worker is just so much work, so intense, knowing how to balance risk aversion from risk management is really, really hard. I get that. It's really difficult. So tip number three is being able to document your professional judgment. That means that things are not black and white. Things are going to be difficult. You're going to have to document your professional judgment, because there are going to be some times where you say, oh, one guideline tells me that I have to protect this, but another guideline says I have to share this much. Be able to rehearse in the gray. Not everything is black and white. Can we go to the next slide? Hospital workers are allowed to receive as much information, whether it's in the emergency room level of care or the inpatient level of care, which is considered a higher level of care with more protections, more guidelines, more restrictions in the inpatient level of care. But hospital workers are allowed to receive as much information as can be attained from family. I still encourage workers, to be prudent about what type of information is being shared out. However, we can receive all the information. And once a person does become a patient, we can ask the patient, hey, would you like to involve your family? And we'll ask them to sign. And this is for all our folks who are perhaps family who have never seen hospital documents. If we go to the next slide, once a person does become a patient, we can ask them to sign a release of information form. And this is kind of like what one looks like. I got this off the state website. And we want to make sure that we're indicating the purpose of involving the family. How much are we planning to share? Are we going to share every little detail? Or are we going to share just enough to make sure that we have minimized risk of all of this crisis ever happening again? If we go to the next slide. So what happens, however, if I as a patient decide, no, I don't want to sign a release of information. I don't want to sign it. I'm encouraging staff to always honor my right to my identity as a patient, my autonomy. NASW, National Association of Social Workers, has it as an ethical responsibility to honor self-determination for our patients. It's one of our values to give them dignity and worth as a person. And I'm going to bring back John's comment of risk aversion is not the same thing as risk management, because if we go to the next slide, I'm going to reflect back on that other tip, knowing how to document. You want to document your thought process. What if the decision to not sign an ROI is part of the healing process? That's why we're called to be very thorough clinicians, to think in gray. Things are not black and white. What if, for instance, we can make the case that yes, the not signing a release of information is part of me as a dignified person, but at the same time, bringing in those healthy natural supports is going to be therapeutic in the long run. This is where your documentation is so important. You want to be able to put two social work values, the dignity of the dignity and worth of the person, versus a possibly conflicting value of the importance of human relationships. All those come out in our ethics, our NASW ethics. What if it's a good point to address in therapy? What if you include this as part of the discharge plan? Interesting that you're living with family, but you don't want to share some parts that might be helpful to the therapeutic process. In your discharge plan, can you include that as a goal of therapy as you're getting them appointments with a psychotherapist? Everything you do is not administrative, it's clinical. It could be wonderfully clinical. Everything could be very empowering. What if a hospitalization could be an empowering process? What if HIPAA and the Texas Code are starting to realize that there's actually a lot of wonderful opportunity to minimize risk by actually bringing in trauma-informed care? Can we go on to the next slide? And here comes tip number 3. Let's say a person is refusing to sign the release of information, and I'm tempted to not involve family. As a thorough and effective clinician, I want to challenge folks who work in hospitals to talk to the physician, because in the state of Texas, only a physician can determine capacity. And what is capacity? It's the ability to reasonably appreciate the risk and the benefit of a decision. To have capacity to refuse to sign a release of information, or have capacity to understand what signing a release of information document is. So if somebody's actively symptomatic and is under too much stress to even understand what they're signing, is it ethical for us to even get them to sign an ROI? However, that doesn't mean that we don't contact family. That actually means we're called to talk to the doctor and say, Doc, listen, I want to reach out to the family, but I don't think my patient understands what it means to involve the family at this point, but it's really important to gather some collateral. The doc is going to say, yeah, absolutely, in the patient's best interest. And we want to make sure that your license is also supported by what the doctor documented, saying that, yeah, in the patient's best interest, we went ahead and contacted the family. And this is even within an inpatient setting, which has a lot of restrictions and protections. So that's tip number 3. Learn about capacity and when you can act on calling family when the doctor determines that the patient's capacity might be compromised, to understand the benefit or the risk of signing or not signing a release of information document. I encourage you in the process to develop a relationship with your physician, because if it becomes too bureaucratic to do so, too bureaucratic to determine whether an ROI should be signed or not, it's not going to happen. Right now with COVID, the number of shelters, emergency shelters, is it's incredibly sad and scary. That if I'm a social worker trying to discharge a patient who is pregnant, and there are no shelters right now accepting anybody, and the few shelters that are accepting patients or residents are full, I might have 1 hour to solve this practically impossible situation as a social worker. And if the family member of another patient is calling and calling and calling, I'm going to have to triage or prioritize my activities for that day. And so I'm also bringing this up because there are times, many times, when social workers really would love to involve the family. Sometimes our day is cut short by the intensity of our work. So minimizing the bureaucracy in order to reach out to family is always going to be very helpful, so that when we triage what we have to do, when I start prioritizing what I have to do, if I can lower the barriers to getting that step done, it's going to be very, very helpful. So that's part of tip number 3. Can we go to the next slide, please? So because we're focusing on crisis stabilization, I want to throw out the slide indicating the different levels of care. An LOC, level of care, is how we talk in social work world about what would be best. Oftentimes I'm called to assess a situation and determine what would be least restrictive for my patient to get the best outcome possible. The least restrictive, most appropriate level of care. If there's a moment where somebody's in danger, we access the nearest emergency room. Sometimes they're called emergency departments, and that gets really confusing when we're talking about ED is emergency detention or ED emergency department. The good old ER. We also have a psychiatric emergency service, PES, and our community health leaders have brought together a PES system throughout San Antonio that helps within a 48-hour period determine if a crisis can be stabilized with without having to go all the way through an inpatient process, or it gives doctors enough time to determine if an inpatient admission is going to be necessary, which is the next level of care. An inpatient stay can, on average, is 3 to 5 days. Usually within the first 72 hours, a psychosocial assessment is performed. It has to be performed within the first 72 hours according to state guidelines. And so that's when it's very important to be able to reach out to family and fill in those gaps, so we get enough information to prevent this crisis from reoccurring. And those first 7 days, once a person is discharged, I'm sorry, I skipped the step down in transitional units. Sometimes we discharge to patients home, to their loved ones. Sometimes we'll discharge to a step down program or a transitional unit, because maybe a full inpatient stay when there's locked doors and regimented schedules aren't so necessary. We can get into more flexible environments. A step down or transitional unit allows for maybe a week or two of letting the medication kick in. This idea that medications are silver bullets and they work from one day to the next we know that that's not how it works. It takes 2 or 3 weeks sometimes for some medications to show any kind of effect. So transitional units or step down units allow for that time to happen while affording a safer space. And then those first 7 days after hospitalization are so statistically relevant to avoiding a repeat in crisis. And the research shows that if somebody has, particularly if they've got a co-occurring condition like diabetes or metabolic syndrome or some type of heart condition, getting a follow-up appointment within 7 days of discharge statistically lowers the chances of getting re-hospitalized in those first 7 days. And then there's the first 14 days. But we always want to make sure that there's a case management contact or a contact with your psychotherapist within 7 days to bridge a gap in services, to be able to get a chance and process what just happened. That was a crazy week. That was out of control. Oh my gosh. Being able to revisit once we have some lucidity. What happened to me? What just happened? Those 7 days are so critical after a discharge from an inpatient unit. And then the last tip is, which is my last slide. Can we go to the next slide? Is a safety plan. Safety plans are so incredibly important that they ought not be kept in one piece of paper and written only once. This is a living document that I like to revisit all the time. If I'm in a change process, let's say I'm even wanting to I want to get healthier. Adopting this schematic for a safety plan is very helpful. The first part of a safety plan, what events led to this crisis? By the way, this is tip number 4, always have a safety plan. What events led to this crisis? Missed medication? There's a relapse to substances? Are there medical conditions exacerbating it? How about life? How about COVID? Didn't expect that one coming last year. And what were the warning signs that these things were affecting me? Was I not sleeping the same way? Was I starting to isolate? Was I having more arguments with people I absolutely love? Was my work attendance being affected? These are those warning signs or heralding symptoms. Can I access internal resources? Some folks have rehearsed those breathing techniques of breathing in for 3 seconds, exhaling for 6 seconds, or developing insight and being self-aware, being good self-advocates. The next piece of the safety plan is external resources or having helpful distractions, or like I like to call my dear friends, my reality bases, because sometimes my own insecurities, my own fears will get me to have a completely distorted view of what my reality is. Who are my people? And then the social supports, my case manager, my counselor, my psychiatrist. And I always give out this phone number, the crisis hotline. Those are the last of my slides, but I wanted to make sure that folks, there's a social worker named Joseph who pointed out, don't just focus on the negatives, focus on the positives. Emergency room visits can have such great benefit if everybody can be together and have this freedom to act. As HIPPA and the Texas codes, thanks to John's education, we're realizing we actually have a lot more empowerment in this process. We can, being able to come to the emergency room and get medically screened. We can get a much better diagnosis. If this might not just be psychiatric, this could also be endocrinological. We're forming a community, and I'm incredibly proud of being able to be part of a community where folks like Terry Mabrito and Mike Lizito and Gabriel Gonzalez and Doug Beach and Dr. Sally Taylor, and the people are coming together. And Judge Kazin said, we have a right to have bad days. We have a right to have hard days. We have a right to have our mental illness. We don't have a right to put ourselves in danger because of it or put somebody else in danger because of it. But that also doesn't mean we have to be disempowered in the process. So revisiting those 4 tips, I hope helps us make sure that our communication is clear, knowing that it's not black and white and that we're going to have to put on our clinical hats and get messy with the documentation and say, this is why I involved family, because it was for the patient's benefit. Anyway, so those are my tips, and I hope that it was helpful and I stayed within the timeline.
Okay, sorry about that. You were muted, Mike. It's
Okay.
probably almost time for you to give another link and another code.
Okay.
And by the way, this journalist was taking notes. So there.
Charlotte.
Just thank you for the wonderful presentation that you all provided. To me, it met up to expectations. I do want to let everybody know that on the individuals for the CEUs and credit for this particular session, the sign out code is 70. So I think you have about 15 minutes to get all that done and uploaded on there. So that's the sign out code. Also, we wanted to reserve time, and I really appreciate the speakers allowing that, because I'm sure on there, in the chat, there were a lot of questions going back and forth, or just discussions on there. But one of the things is they do want to get copies of the slides on there. So if you don't have a problem with that, I'll get with Terry on there to try and see what we can do. Can we post it on the NAMI website or Pathways? for somebody to pick that up, or we could probably even do it for our Bexar County mental health department to have the slides there also. So we'll figure that out on there, and but hopefully it'll be on the pathways, and that way you won't have to search for it. But we'll try to get you back that information, because I'm sure a lot of the presentations have had slides and so forth that individuals are interested in. I did want to kind of talk about, I think both of you kind of hit it really well on the nail. In John, and your end of it, by saying, hey, it doesn't always have to be in writing. You could be there can be some discussion on there based on that person's risk. But the other thing too that I saw was that, Lewis, you had talked about, and I want to get some comment from John on it too, is about reviewing the incident, what happened, and kind of after the person discharges on that, to say, okay, with those 4 tips that you had, you kind of think about it, and that's really something that we hear, especially in NAMI, having been a member of NAMI for a couple years here, and participated in family to family, and just in discussions with family, they talk about what had happened, and either their condemnation of the system or how it went. But from both of your presentations, sometimes with having this knowledge now, it could help them to have a better experience with their loved one or themselves, and then how can we be more successful. So I guess my question on there is, Lewis, on there, when you started working this up, so this was what you started seeing when you were working on discharge plans and people getting out of the hospital, and maybe some of the feedback that you had gotten?
Right. And so I took a training on crisis response programming through the Strong Start Consortium, which is part of the medical school here in San Antonio. And it's a huge international consortium studying actually PTSD with veterans. And so they came up with this amazing crisis response programming where you're identifying triggers, and then you're also identifying what was happening at that day. So often we're so scared to talk about suicide. We're so scared that there's a myth that if we start opening it up, it might encourage somebody to complete it. And this program, and I don't mean to speak for them because I'm not licensed to represent them, but that's, if you're asking me what opened my eyes into like what do we really need, that type of training through the Strong Start Consortium really lets you know that's like, be evidence-based. Look at the literature. It's a myth to think that if we are bold enough to address it, bold but compassionate. Trauma-informed care says create safety. Address those risky moments. And what happened when you woke up that morning? And did you wake up by yourself? And was there anybody in the house? And did you make yourself a cup of coffee, or did you forget to make your coffee? And go very detailed and be unafraid to visit the issue of that crisis moment. And the beauty of about the crisis response program is that they actually turn it into a psychotherapeutic session, and they revisit that plan over and over. And it's so beautiful to be vulnerable but courageous at the same time. And I'm very much like what a soldier would have been. But that's what I realized, that, hey, we can bring this into the civilian world. Actually, in the literature for trauma-informed care, they're asking for civilian trauma to be more in the literature, in research. University Hospital is the level 1 trauma center. We acknowledge that we're vulnerable, and going in and exploring what got me to that point where I thought I was unworthy of love, unworthy of giving love, that I was helpless or hopeless. Go there. Create a safe space, go there, and then provide continuity. Don't just open it up and try to put a patch on it and send it on its way. No. Really get in there, be that effective clinician.
Thank you so much, Lewis. And I think, John, on your end, because you're into the research, working with Meadows Mental Health Institute. I know you work with cities and counties all over the state of Texas with increasing capacity and so forth. So on the research, one of the things that Lewis had talked about was that 7 days after discharge and making sure they get connected. Are there any other things that you could enhance us with as far as what could help families and can help clinicians and to understand better so our successes are better? Because I know one of the things is that continuum of care in that process and making sure not everybody, I know we're working very hard in San Antonio on silos and how do we address those silos, and having that web-based system that tells you what's been going on with that particular person, so you're not reinventing the wheel. So anything that you could provide on that end of it?
Well, yeah, a couple points. I think one is that, as Lewis said, there's a risk of readmission if you don't do good continuity of care, obviously, which has financial implications for hospitals and emergency rooms. Sort of the best studies that have been done about the relationship between mental illness and violence find that the biggest risk of violence to third parties, if it's going to be a risk, is within the first 30 days and more likely the first 10. So I think everything pushes us in the direction of enlisting folks in the interest of continuity of care. I got interested in confidentiality long before HIPAA, back in my New York days when we operated 6 kids' hospitals, and families would come to me and say, we admitted one of our children to your hospital, now I can't learn anything about it. And at that point, and it's still, I think, relatively in the ballpark, 65% of all discharges from psychiatric care were back to family. And so we would hold family at arm's length and say, we can't really tell you anything about it. And again, this is not to cast stones at clinicians at all. This is just sort of the reality of the situation. And then when it's time to discharge, well, now come get your adult child and good luck. And so it's trying to navigate that space and permit families to be part of the continuity of care, unless the person in care just says, no, I don't want my family involved at all, and then you have to respect that. But that's not often the case, or not always the case. And then recognizing that, in my experience, again, most families I've talked to about this, they don't want to read the whole record. They just want to give me some information to help. Give me something to know is what my child is experiencing a side effect of medication, is it symptomatic of illness, is it something else? And so I think what the Office of Civil Rights at the federal government has done a very nice job articulating situations where you can provide some information to families without running afoul of confidentiality rules. It's in the interest of continuity of care. So that's, part one is got to deal with continuity of care. And if we don't, the consequences within a very short time are significant. Second is there's space to bring families in, just as we've done with peer support, right? One of the best things that's developed in this field in terms of justice-related issues is bringing peers into the conversation. And then the third is recognizing that we have we're trying to navigate a space between being respectful of privacy, but not being stupid about continuity of care. And people have to navigate these complex systems, and we need to arm the clinician, the patient, and as appropriate, the family in helping people do that navigation. And the law, generally speaking, permits that. That sort of space to be found between clinician, patient, and family.
That's good, because I think one of the things that we find is, and that I've heard, if the person's not willing to sign on there, that the family can still relay, right, information to the doctor. They may not be able to communicate back and forth and say, oh yeah, this or that, but if saying, I guess, if Johnny was here and if Johnny did this, then you may need to be aware of these types of things on there until they can work with Johnny to try and get them to sign the release or do what's necessary or determine what the risks are in order to involve those natural supports.
Yeah, just as you said, Mike, and Lewis made this point too, I want to emphasize it. There's nothing in any legal rule that says a clinician cannot get information from anyone they want to get it from. Now, again, one exception, right? If I tell Luis is my clinician, I say, I do not want you under any circumstance to go talk to my spouse, my brother, whomever, then he has to respect that if I'm competent to say that. But generally speaking, clinicians can get information from anywhere without running afoul of legal rules. And so I think Luis made that point. It's an important point to emphasize because sometimes there's confusion over it.
And then also, I think on there, John, one of the last ones on here is with COVID, they've opened up telehealth, right? And my understanding, or at least my discussions, and I'm sure there'll be some data that will come out about that, but even in a treatment program, what they have seen is that by using telehealth, their show-up rate has increased tremendously on there. That as far as no-shows, that's not happening as much, and they seem to have better communication and contact with individuals. After COVID ends, or whatever that period of emergency is, do you think that's going to continue, or what do we need to do as citizens to make sure that is in legislation or part of that, to be able to use telehealth for the mental health and health and for counseling?
Well, I think at a federal level, and then I'll ask Luis to chime in at sort of his at the clinical and Texas level, but the relaxation of rules around information sharing, telehealth, and the others were done sort of after declaration of an emergency because of the pandemic, and that was a necessary kind of legal step to make that declaration. What I anticipate, first of all, we're not going to see an end of the declaration of emergency anytime soon. And second, I think there's going to be tremendous sentiment to make some of those relaxed standards a part of the formal rule. So I would anticipate, even if the pandemic ends, whatever we mean by that the feds would go out and solicit comment and then make some significant part of what's been done part of the formal regulatory structure of HIPAA. And then Texas, the legislature and the regulatory agencies here have also taken some steps to try to make telehealth easier to use. And I think it's a huge, we want to use it to the degree it's useful clinically. So I'm optimistic about being able to maintain a framework in which it is more readily used, recognizing at all the data security issues that are always vexing us.
Thank you. Luis?
Yes, so I think that I'm also very optimistic. I'm optimistic that there's going to be different sampling for research, because we're going to see what were the outcomes of telehealth. Now that we have higher participation in telehealth, what were the outcomes? Did it actually improve quality of life? Did it improve care? Also, a lot of third-party payers, private insurances, follow what the guidelines the Centers for Medicaid and Medicare set. So once we go back to not having a pandemic, our insurance company is going to be reimbursing clinicians for telehealth the way they were doing it during the pandemic. I don't know. And if they don't, then it's obviously not going to be financially solvent for any clinician to be able to hold a business. So I think the data will show, and I think the research is going to have to be driven to see what were the outcomes like during this period. And there's some wonderful research groups going on, so I'm excited about that.
Thank you. We have a few minutes. Any closing remarks, John, on your end?
Just to urge people again to recognize the importance of privacy, as people do, but that when we're talking about legal restrictions, let's make sure we understand what the law actually permits before we decide that it doesn't let us do something, and then take our ethical principles and how we apply those, take clinical sort of circumstance, and then, on a case-by-case basis, people may decide they're not going to go as far as the law permits, but at least recognize that the law often gives us much more flexibility than we take based on misunderstandings of the law. So I will stop there, but that's my main kind of purpose in this, is to try and get people to appreciate that.
Thank you. Luis?
Two things. I'm speaking to parents of their adult children who have to go to the emergency room and say, "Where is my son? Where's my daughter?" That one daughter, that son that they were carrying during this horrible crisis moment. That if we picture that, there's a phrase that comes out a lot where the hospital worker says, "I can neither confirm nor deny that your loved one, your child, is with us." I want to take that phrase as a closing remark and just kind of this summarizes it. From the parents' perspective, this is a part of them. This is a child that they were probably in danger with very recently. To be told that that child of theirs doesn't exist and there's no confirmation of their existence is a horrible experience. So I'm encouraging staff to think about how that statement is going to be received. I understand it's clean, it's clear, it's legal, but remembering what it feels like to give birth and to see the suffering child and then to say, this child doesn't exist, I can't confirm its existence, is one bad thing. But then I also want to encourage the parents to understand that staff member may also be working on another patient's situation where they're being discharged to the streets, because right now with COVID, there's nothing available sometimes. Sometimes all those shelters that have courageously reopened or are courageously staying close to protect their residents are not available to help. And there might be some real crisis happening inside the worker at that time as well. And saying something like, "I can neither confirm nor deny," is actually perhaps the most compassionate thing they can muster at that moment. So I just wanted to be able to bring those two perspectives and say, this is what NAMI does. It brings it to the same table, and then so that we can better understand each other. And I think that's wonderful.
Thank you so much. And then that plug for NAMI, I do want to say that the family to family, the peer support, all the programs that they have for everybody out there. If you're not aware of them, please get in touch with your local NAMI and utilize them, because the more you know, the more knowledgeable you are as a parent, as a clinician, wherever you are in the system, the better off everybody will be on there. So, power, that knowledge power, it's very true in especially when dealing with mental illness. It's always a challenge. So this concludes our workshop. They will have the evaluation. Hopefully I've covered everything and everybody was able to fill out their CEUs and get those in time. But thank you so much for letting us join you.
My honor.
Thanks so much, very much. It's a privilege. Thanks.
Thank you.
Thank you, guys. You were great.